Sorry if you thought you'd heard the last of me. So yes, I'm going to be talking about upper limb rehab, and I've got my colleagues here who will be ably backing me up in that. So again, like I started before, what we wanted to go through in our upper limb boot camp, which is what we created, is why it was so unacceptably poor. And so what we looked at is, I'll break down some of this literature here for you. 66% of patients have paresis following stroke admission, and 50% remain without function at 6 months. Only 5 to 20% achieve complete functional recovery. Patients engaged in activity for only 13% of the day, and that's research from 2004, and I'd have to say that it hasn't changed dramatically since then. Upper limb rehab really only contributes about 4 to 10 minutes per day, and typically only about 30 to 40 reps per session. CIMT, which Louise is going to talk about a little bit further, is accepted, but less than 65% of therapists use it. Practice of task-specific functional upper limb movements in only 51% of upper limb sessions. So not unlike the lower limb research that I was presenting before, outcomes of upper limb are even worse than what we see in walking and gait. And therapists overestimate therapy time by about 28% or 17 minutes per hour. So even though they're doing a gait and upper limb training session, they're actually overestimating the number of repetitions and the time that's spent in that therapy program. So prognosis of upper limb post-stroke, we know that people don't typically improve their upper limb post-stroke as well as they do lower limb, and there's lots of reasons for that. It may be where the stroke actually occurs, the severity at onset, it might be where the lesion is actually located, whether it's on the outside of the brain or whether it's more in the mid-centre of the brain. That can actually affect where it happens, the size of it. We don't really know typically in a clinical context unless we actually use something like TMS or an MRI to see what tracts are still viable and still intact. There's one particular tract called the corticospinal tract. If that's actually impacted, either from a stroke on the outside of the brain or the inner internal capsule there, we know that recovery is going to be impacted, and you may not return that discrete function and that fine motor control again. So we might be needing to explore more gross motor function and compensatory trainings, but we wouldn't typically know that in a clinical setting because we don't always have access to TMS studies. There is spontaneous recovery. We know that people will typically recover some function after stroke if possible, but spontaneous recovery is not typically enough. We know in walking, if you want to get from A to B, you will typically get up and try and walk from A to B, usually and hopefully with guidance. But upper limb, there tends to be this learned non-use, this helplessness, this habitual non-use that people adapt as well. And so you're not forced to use your upper limb like you would be lower limb as well. And that certainly contributes to the lack of function that we see in a lot of our upper limb patients as well. And then that leads on to secondary impairment, so you get soft tissue changes, you get secondary weakness because you're not using the upper limb, you might have spasticity that limits function as well. So in terms of accepted theories in upper limb rehab, the goal of rehab is not only to increase repetitions, but also to engage attention and effort. And we do that because the more interested and engaged you are in a particular task, the more likely you are to give it your all. And that's really important. Salience and task-specific practice is what's going to carry over into real-world function, which is what we were talking about in the last presentation. And increasing therapy time really comes from, leads to increased outcomes, both in the acute and subacute setting. So what we were talking about before with the Lexo, we want to overall increase the number of repetitions that you're doing. It's very important that the repetition is high, but also that the level of intensity is also high, as is your engagement level. Monotonous exercise, which is what can be, what often leads to lack of interest, lack of engagement, can provide worse retention of skill. So it's not uncommon for you to be set up with an activity that you need to complete 300 repetitions of, and it might be a really boring task with not a lot of progression, not a lot of engagement, and not a lot of challenge. Those are the tasks that are not going to achieve the long-term outcomes for your upper limb function. Physically guiding a movement can decrease motor learning. This would be for all the Bobar therapists out there. But sometimes if we actually help as a therapist, we guide that movement, sometimes we can actually take away some of that error and the ability for you to learn that moving that way is not appropriate, it doesn't work, it hurts, it's inefficient, etc. So there's just a balance that we need to accept as therapists about how much we can get our hands on you and how much we actually need to have you practice. And something like Robotic Devices, they will actually guide a lot of the movement for you, opposed to goal-directed task-specific function where you might have an activity where the outcome is what is actually measured, and how you get there might not be as big a significant contribution. Robotic therapy can decrease recovery if slacking is tolerated. Again, this is just enabling you to let the machine do as much of the work as possible. And we talked before about that passive function in the lower limb, where that actually was found to be really useful. In upper limb, it tends to be less useful if the machine is doing more of that manual function for you. Learning is error-based, so how you learn and how you recover some of your movement, you need to make those errors in order for you to learn and reprogram your brain about what is efficient and effective for you. So an upper limb example might be you reach for a glass, and this might be a very typical movement pattern, because it's much easier for you to try and do this and draw in the muscles that work than try and draw in muscles that might be much more efficient for you, and that can obviously lead to a lot of pain, a lot of impingement, a lot of discomfort that way, but it actually gets you to the task, and you continue to do that because that's the only way that you can get your arm to achieve that particular task. And so as a clinician, we might want to come in and actually revise that and try and encourage you to do that, but obviously it's incredibly frustrating if you can't do it. And then over time, monotonous practice of that, you might just completely abandon the task. And that's why we have to look at ways that we can make you more efficient and get lots of repetitions, enrich the environment, and typically that is around the robotic context that we were mentioning before. All right, so the desirables of robotic use. I was talking before around getting you set up in a therapy session, upper limb training session, where we're wanting you to do 300 repetitions, because again, we know repetition needs to be high, intensity needs to be high. How do we then make sure it's really engaging for you, and how do we make sure that it drives neuroplastic change? So neuroplastic change is, again, making sure that we can make those efficient pathways within your brain and prune away some of the more redundant pathways that are leading to compensatory movement patterns. So we want to drive neuroplastic change, and the way we do that is with intensity, specificity, so it's very specific to the task, it's very specific to the outcome that you want to achieve, and it's very relevant to you, and where possible trying to reduce some of those compensatory movement strategies that you've adapted. We've talked about creating an engaging and motivating environment. This is absolutely crucial. If you are bored out of your brain trying to achieve those 300 repetitions, you're not going to do it. It's like anything, you know, there's a reason why it's $1 billion industry, the personal training industry, because somebody's there telling you what to do, they're making it interesting, exciting and engaging for you. You need sensitive assessment tools, and as good as we can be as clinicians, we can at best often only eyeball. So we can, you know, we're very restricted in what we can look at in terms of the minutiae of less than grade 1 muscle activity. So if you can't really move your limb very much, we can't do much to eyeball that and be objective in that. So we need equipment that's sensitive enough to pick up the minutest movement, either for range of motion, for strength, for pressure, all those sorts of things, because we're fairly limited as individuals to be able to capture that and act on that. Interactive feedback, again, if you make an error or you make a successful movement, being able to get immediate feedback and reward or notification around that is really important as part of your learning process as well. And we also need to make sure that you can do whatever you're doing in the clinical setting in an outdoor real world context as well. So typically your therapy needs to be variable, and it needs to be random, and it needs to be contextual to what you're going to do when you go home. So if it might be picking up a cup in the clinic, it needs to be very much associated to when you go home, how are you going to do this, where are you going to do it, what cup are you going to do it with, what's going to be in the cup, and how you're going to make sure that's a successful movement at home as well. And for the reasons that we talked about before, if it's more relevant to you, you're more likely to do it, and therefore it's daily tasks and daily activities that often form the basis of what you're doing in a clinical context, so that you can go home, repeat that, but it also has an impact on your daily function. And where possible, we want to enable independent practice. So whatever we do in the clinic, we want to be able to set you up for a homework program so that you can practice that at home. Or if you're practicing how you bring the cup to your mouth in the clinical setting, every time you do that at home, you're thinking about what you've learned from your therapy session. And ideally, it needs to be a cost-effective and practical model, and easy for you to set up so that you can transfer that into a home-based setting as well. So that's why we started to introduce a lot of robotic devices into our clinic as well. So we've invested really heavily in robotic devices, which is why I'm here talking about upper limb therapy in this session. So we've looked at what the limitations are in upper limb rehab, and as we've mentioned before, a lot of that comes back to the same things we talked about with lower limb, is we typically don't get the number of repetitions, we don't have the level of engagement, we don't have the level of enjoyment, we don't have the cognitive investment in the program, and it's not translating into real world change. And so what we looked at was bringing in some of these devices, and so this is a device here, you can only just see the base of it. I'm trying to go backwards, sorry. Does that go backwards, please? Can I go 3 slides back? Hang on. I found it. Sorry. So there's devices here. This is the Miro, and this is basically like a massive iPad. And what's beautiful about this device is if you've got neglect, which means you don't really acknowledge one side of your body, you can style the computer-based software so it only works on that side where you have neglect. And it's a touch screen, so not only is it interactive, it does computer games, which again, for the reasons I said before, are incredibly motivating, and we really struggle to get people off this device because it'll be pitched at the level of that individual. So if somebody's got cognitive impairment, it might just be coloured dots that you have to touch, and therefore you are moving your arm because you get a reward, you get points, or you get a big bang if you actually touch the dot. And what's really lovely about these devices is you can set the parameters and the range for each individual. So if I can only move that much, then I will set that as my range for the patient, and then I might say, yes, I want them to be able to work at up to 100% of that range, or let's just get them working at 50% today. And so the game will actually be rescaled and recalibrated to that much movement. And that's fantastic because then you can intrinsically move that range as they continue to improve. And so there's internal algorithms in this software as well. Once they achieve one level, it will move them on to the next level. If they create too many errors, it will take them back a level. So again, we're constantly enabling individuals to feel reward and satisfaction and achieve those gains, which means they'll come back and do more practice. So getting somebody to do 300 repetitions on a device like this is almost easy when you compare that to setting up a station at a table, and you've got a target that might have a bell that they have to ring. You can see the difference in that context immediately, and that's where we can use computer interactive software and robots to really enable us to get the dosage in therapy. This is another device here which is really lovely because we really struggle to be able to help people with opening out their hand. So if somebody's got a lot of spasticity, it's really difficult to release. To release if you're holding onto a cup and you need to release. If you've got a spoon or a knife and you need to release, it's really hard. This device will actually give you immediate feedback about how much active work you're doing to release, and if you can't, it will start passively and then you can override the device. And so what we found with this device is it's absolutely lovely for people. It'll start off passive, take the hand through range, stop people fighting against it, and that's the first thing, is learning how not to fight against it. And then it'll actually start to guide some of that active assist, and then over time you can build in some of the active movement. And we find that there's some lovely carryover. If we do this for 20-25 minutes before a session, then people can practice that active release, and then they'll come over to a station and then they can actually practice on different tasks and objects that same release movement that they've been practicing, and they're primed for it. We've got other devices where we can actually look at different ranges of movement. So things where we put sensors on the limb, so it might be on the wrist or the shoulder or the hip. We can actually gauge range, and as I said before, we're not sensitive enough as humans to eyeball that kind of movement, but with this technology we can actually identify 4 degrees of movement, 5 degrees. That was 6 degrees better than yesterday. That's fantastic, let's keep going. And so it's that kind of building on success each day, and we get reports back which are very, very motivating for individuals. And then you can go back to old school rehab immediately after you've primed with a particular robotic device, and this is something that somebody might take home. So you'll practice on the robot in the clinic and the computer interactive software, set them up in a translational activity in the clinic, and then that's what you're going to go home and practice. Maybe another 300 repetitions at home with the view to coming back to the software tomorrow, and let's see what you can achieve. And there's some really lovely devices that can go into lots of different movements and really facilitate movements that as individuals we can really struggle with in therapy. So this is just a Pablo, which you will end up playing a game doing this particular movement or this particular movement, and you'll do hundreds and hundreds and hundreds of repetitions of that particular movement, trying to put a fire out or whatever it might be in the game. And then you've got blaze pods. So as you continue to improve, you can be really reactive and dynamic with your movements as well if you're much higher level. So this gentleman here is reaching down, reaching out to turn off different lights, and they're randomly coloured. So he has to touch with his left hand, left foot, right foot across this space. So he's got to be thinking, cognitively demanding, and also stretching out his limbs. And that would be for somebody that's quite high level. So our upper limb intensive really demands the same focus that we spoke about before. We want to be looking at people 3 times a week in the clinic for about 2 to 3 weeks. Just as a kickstart, setting you up for what you're doing at home. We look at motor activity logs to try and build that into your daily rehab as well. How do you make your bed? How do you get the dishes out of the dishwasher? Let's try and focus on all the ways that you can incorporate what you're learning in clinic into what you're doing at home, and trying to build up to those 5 or 6 hours of rehab a day as part of your daily life. So if you're interested in more information, I'm really happy to chat in the question time. Thank you.